I'm Josh Green, your host at Healthcare in Hawaii. Welcome back. Over the last several weeks, we've really begun a journey together to discuss all the aspects of healthcare in our beautiful state of Hawaii. We started with Beth Giesting, the governor's healthcare transformation czar, to talk about what they're doing to transform the healthcare system in general. We moved to the insurance industry and talked with Senior Vice President Hilton Rathel about what HMSA does to try to make healthcare more accessible in our state. We then talked with Jairus Hedges, the Dean of our medical school, and he talked about how we're helping to grow doctors here in the state of Hawaii. We moved our attention over last week to the Health Information Exchange with Christine Sakuda. And now today we have a really distinct luxury of having Professor Keawe'aimoku Kaholokula, who's a PhD here in the state of Hawaii, and really become an expert on the challenges and disparities we have in healthcare access in our state. We're going to talk about things such as the social determinants of health, a concept that for many might be difficult to understand, but with his expertise we will be able to see that that is at the core of access issues and quality health for many people in our state. I really appreciate having these experts come and talk with us because healthcare has really been the buzz as the main issue that has consumed the country's attention. So without further ado, I'm going to bring you Professor Keawe'aimoku Kaholokula to begin to enlighten us on the social determinants of health.
Mahalo, Senator Green.
Great to see you.
Thank you for having me. Well, social determinants of health is basically the social and economic forces underlying some of the health disparities we see in our population in the U.S. as well as in Hawaii. And health disparities exist when there is a higher morbidity or mortality rate or incidence and prevalence of diseases such as diabetes, cardiovascular disease in a particular population or part of our population. And most often the discussion around social determinants of health is around ethnicity, ethnic and racial differences here in the U.S.
I've noticed that in Hawaii people think that, oh, everything is fine if you live in Oahu, you have access to health care. A lot of people say we have great hospitals. Yeah. Maybe it's more challenging on the neighbor islands, but it goes a lot deeper than that, doesn't it?
It goes a lot deeper. I mean, if you look at it, good medical care, access to good medical care, genetics and biological factors, as well as behaviors collectively, when you look at the bigger picture, accounts for roughly 30 to 40% of the diseases we see. The other 60 to 70% are what we might consider social factors, education, income, housing, and so forth. So when you look at the bigger scheme of things about a person's health and well-being, it really goes beyond a clinic. It really goes beyond a hospital and goes upstream.
See, this is very important because in the last few talks we've had, we started out with looking at this healthcare system and say, how do we get people insurance, right? And I think that's important. I mean, the Affordable Care Act's been talking about that for the last couple of years, and we know in Hawaii we have about 120,000 people that are uninsured. And you know, I appreciate when people can break it into their area of expertise. So we talk about the number of uninsured, and we talk about the physician challenges and the physician shortage, of which I want to definitely get to that sometime today, so don't let me forget. But then once we kind of peel the layers of that onion off to really get to what makes for a healthy healthcare system, I think you've really discovered and touched on a much more complex healthcare challenge than a lot of those other conversations have been.
Yeah.
So tell me more about that.
Well, you know, our department actually did an assessment across the state of Hawaii, talking with healthcare leaders in our communities at community health centers, and we wanted to get their ideas about what the last several years have been like for the status of Native Hawaiians and Pacific Islanders and where we are today versus where we are 10, 20 years ago before our department was even established. And you know, although we've made many accomplishments, we've moved forward in many ways. I mean, for example, Native Hawaiians, the longevity of Native Hawaiians have increased over time, as well as all other ethnic groups. That's the good news.
Yeah.
The concerning news is that despite that increase, we still die at an average of a decade earlier than people of other ethnic groups.
But how does that break out? When you're describing someone that's Native Hawaiian and you see that additional morbidity and mortality, in other words, dying sooner, as much as a decade, does that mean you had one parent that was Hawaiian or that you're all Hawaiian? How is that?
Well, the individual will have Hawaiian ancestry regardless of degree of Hawaiian ancestry.
Okay.
And that will be defined as a Native Hawaiian in that sense.
Okay.
And so a person with Native Hawaiian ancestry, regardless of the degree to their ancestry, on average seem to die a decade sooner than other ethnic groups.
My wife is 50-50. she's Hapa with Japanese and Hawaiian, and her mother died at age 40 of stomach cancer, and her mother's mother, my wife's grandmother, also died in her early 40s. And it just, it breaks one's heart to think, because as a physician, I'm a loving husband, but I also hear the story as a physician, and I know that those were diagnoses that maybe should have or could have been made earlier, and I've seen many, many individuals get treatment. Yeah,
it's unfortunate in our Hawaiian and Pacific Islander communities, many of them get diagnosed with problems when it's too late. So in most cases, although some cancers are certainly higher among Native Hawaiians, like breast cancer with Native Hawaiian women, but most times it's not so much there's a higher prevalence, it's just that our people get diagnosed at a later stage when, possible good treatments could have been done in earlier stages. They get to stage 3 and 4, for example, and often by then it's too late. So the challenge is getting them sooner, and also looking at why are people getting diseases at younger ages, diseases that were once for older people. We're seeing like heart failure, for example, we're seeing in 20 to 30-year-olds, Native Hawaiian and Samoans.
Yes.
Well, that is due to obesity, and certainly ice use perhaps might be a culprit as well.
Right.
But we're definitely seeing diseases at younger ages, and therefore probably attributing to the earlier deaths.
Well, let's take a step back. Okay, so we said that just by the very nature of being Native Hawaiian, you have an increased probability of living a shorter life.
And it's not, and I've got to make it clear, it's a marker for something else. It's not because of being Hawaiian leads to that. It's because of the socioeconomic conditions, and then going back to the social determinants of health, that many of our people find themselves in. We're the group that is most likely to be undereducated, work in jobs that pay lower wages, a stressful type of work too as well.
Right.
Also live in communities that what we may call obesogenic, communities that lend itself to obesity, where there's less access to fresh fruits and vegetables. There's more fast food restaurants. There is less biking and walking trails and usable parks, for example, and safe neighborhoods.
And all of that leads to higher rates of obesity, in turn diabetes,
heart disease, stroke, and so forth, exactly.
And it seems like also, on top of those social determinants, we also have access issues, is that right?
And access issues as well, and for many of our Native Hawaiian, and many of our rural folks in the islands, as you know, there is an issue which they can't get good specialty care. For example, many of them have to fly to Oahu or wait until someone flies in.
Yes.
And you know that very well, being a physician of the Big Island.
Yeah. Well, I remember when I first came to Hawaii, I was lucky enough to be with the National Health Corps, and I got the absolute greatest luck to be asked to go and work in Ka'u. And when I was coming into Ka'u on Big Island, the only other physician was leaving. She had been there for several years. So suddenly there were many challenges. One, I was a very green doctor, to use kind of the pun, but I was fresh out of residency. I had no experience. I had no peers there that had much more experience in treating diabetes, heart disease. I knew what the books told me. I knew what my residents told me, but then there I was the only physician, and even if I could do an okay job helping an individual, and it was very, very, the population was mostly Native Hawaiian and Filipino actually down in Ka'u, but even if I could do a good job, I didn't have an endocrinologist to help with the diabetes care. I didn't have extra support to work on nutrition. I didn't have so many of those things. I didn't have the ability to, if there were drug treatment needs, if there were any other issues that everyone would expect to have in any community, we had none of that. We had a little bit of care.
Yeah, exactly. So we need to do something about that. We really need to get more specialty care out into our communities, our rural communities and neighbor islands. And we really need to look at what's happening in our communities. Because as you know, when you treat someone with diabetes, what kind of medical recommendations do you make?
Right.
Lifestyle recommendations, right?
Absolutely.
Beyond medication, healthy eating, more physical activity, watch the stress.
Right.
But we're working in a society that competes with that.
Yes.
And most of our Native Hawaiian Pacific Islanders are the most disadvantaged because of their socioeconomic conditions. So we live in a society where many people have to work 2 jobs to make ends meet. And they got half an hour to get to job A and job B in traffic on Oahu. So of course they're going to go to a fast food restaurant.
Right.
It's fast. And they can get to the job B. And they're worrying about the here and now, feeding their kids, paying their rent. That these other things compete with some of the medical recommendations we make. The question becomes, how do we create, how do we work on these larger social issues, especially for Native Hawaiian and Pacific peoples? How do we get livable wages? healthier communities, sustainable, healthy communities, access to their natural resources so that they can live the kind of lifestyles they want. In a lot of our research that we've been doing, looking at some of these other determinants of health,
Yes.
what's really interesting, when you put aside all the biological risk factors we know for disease, such as hypertension and diabetes, what we're finding is stress-related factors are independent predictors of hypertension and other physiological markers of cardiovascular disease. So we did a study looking at Native Hawaiians and perceived discrimination, racism.
Interesting.
And what we've been finding is that Native Hawaiians who perceive more discrimination around them actually have a higher risk for hypertension and also have what seems to be hypocortisolism, less cortisol production. And as you know, most times with acute stress, there is an increase in cortisol production to respond to the stressor.
Right.
But what we know is that chronic, persistent stress over time, the body can't keep up that kind of production, and eventually is actually what they see is hypocortisol, less cortisol production. And cortisol is a stress hormone.
Right.
And that hypocortisolism seems to be associated in other populations with heart disease and hardening of the arteries.
Amazing.
Yeah, so, and it's much like what we see with people with post-traumatic stress disorder, people with severe and persistent depression, people who are caregivers of ill family members, because these are stressors.
Right.
So, you know, above and beyond the typical stressor we have in society that all ethnic groups experience,
Right.
here in Hawaii especially, certain ethnic groups have an added burden. We see with African Americans in the U.S., they have a higher risk for hypertension. It's strongly associated with discrimination perceptions. I use the word perceptions because it's hard to follow somebody throughout the day and actually see whether they're being discriminated against.
Right.
So we can only ask their perceptions of being discriminated against.
Right.
But there's a strong association.
So if I were to draw kind of up a diagram, what you're describing is a population of people that have challenges, but on top of that, on top of the challenges that we have, they're getting hit several different places. First, there's poverty, which creates a stress. Second, there's the need to have two jobs, which creates a stress. And as these stresses accumulate and perhaps racism is also imposed on their lives, they begin to actually have a physical response
so
to that.
wear and tear on the body, exactly. There's physiological changes, abnormalities that lead to disease states, metabolic abnormalities. It's really interesting. There's a lot of research done on social status in both humans and non-human primates. And Robert Sapolsky, well-known neuroscientist, actually wrote a really interesting book, Why Zebras Don't Get Ulcers. Really explains nicely why we as humans are prone for stress-related diseases.
Yes.
And as you know, depression, diabetes, for example, is probably considered a stress-related disorder now because people with depression are 2 to 3 times more likely to develop diabetes independent of your other risk factors. And depression, if you look at it, it's a chronic stressor.
Right.
Yeah. So we know that when you look at social status alone, just someone's social ranking in society, whether you have a high social status, a lower social status, that alone is associated with morbidity and mortality. So of course, people with higher social status live longer, live healthier,
Right.
have better quality of lives. We're seeing that here in Hawaii as well.
Can I break that out for you
Yeah.
a little before we go to our first break?
Yeah.
Just so I understand, we have both the impact of the stressor, say poverty, and the impact that poverty will have on someone. They have the added stress, they have the impact on their adrenal system, and they're prone to heart disease and diabetes and so on. But also, do you see in your research that because someone has wealth, they have access to more specialists, more care.
Yes.
So it's a double whammy, so to speak.
It's a double whammy, more than just access to care. Because when you're under stress, as you know, you crave certain types of foods.
Right.
Foods that are bad for us.
Yeah.
Because they have the most bang for your buck, so to say, temporarily, right? So we crave those calorie-dense sugar foods. So when you're under stress, there's both a metabolic or a physiological factor that leads to disease, right? Which is through craving of certain foods. But when you're also stressed and so forth, you tend not to have time for physical activity.
Right.
You spend more time ruminating over a problem than actually engaging in the kind of activities you might want to engage. So it's a number of pathways actually that seems to all kind of interact a bit that leads. But independent even of diet, obesity, and physical activity, there seems to be an independent biological pathway to disease, probably through some metabolic dysregulation.
And the end result of this dysregulation is?
Risk for diabetes, heart disease, and so forth. And as you know, many of our people with diabetes end up with heart disease. And the number one problem with heart disease actually stems from having diabetes.
And thus shorter lifespan.
Shorter lifespan.
Well, I think that's a terrific point for us to kind of stop for our first segment. Okay. We're going to go to a break here at Healthcare in Hawaii, and when we come back with the professor, we're going to really start unpacking the many different challenges that our community has here in Hawaii, and we're going to talk about the actual disparities in health across many different disease states. Thank you for joining us. I'm Josh Green.
Aloha, I'm Jay Fidel, founder of ThinkTech Hawaii. We are a digital media nonprofit that covers things that matter to tech, energy, diversification, globalism, and progress for our state, the state of Hawaii. We broadcast on community television and on Oceanic Cable Channel 16. We also stream our shows and interviews live on the internet as both radio and video, and of course we post them here on YouTube. We collaborate with the Hawaii Venture Capital Association to present monthly luncheon programs on subjects of interest to the business community, and we write for the Honolulu Star-Advertiser. ThinkTech works hard to raise public awareness in Hawaii. Check out our website, thinktechhawaii.com, and come to our YouTube channel, ThinkTech Hawaii. We hope you support our mission and that you like our work. I'm Jay Fidel. Mahalo.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island and a physician in the emergency department. Today I'm lucky enough to have Keawe'aimoku Kaholokula, who's a PhD and an extraordinary thinker in many issues in healthcare. Over the past couple years, his department, as he's the chair of the Department of Native Hawaiian Health, has produced the Assessment and Priorities for Health and Well-Being in Native Hawaiians and Other Pacific Peoples. This is an extraordinary report that anyone interested in public health or really interested in their community should get their hands on. Keawe, could you please unpack what's in this report for us?
Yeah, sure. So what we wanted to do is kind of give a update on where we are with Native Hawaiian and Pacific Islander health. So we looked across population growth, we looked at the different chronic diseases such as diabetes, heart disease, cancer, and so forth. Mm-hmm. We also looked at what's more interesting, what we looked at in addition to that was we actually again asked people who work in the community health centers and Native Hawaiian healthcare systems across the state, their thoughts. What are the priorities? What are they seeing? Mm-hmm. How have we been doing over the last several decades in the area of Native Hawaiian?
What did they say? What were their priorities?
I think, on average, they were saying that nothing has really changed, actually. It's one of the quotes I believe that we have in here. Nothing has really changed. It's just gotten worse from their perspective. From the broader perspective and looking across data sets in the state, things have gotten better in many areas that would affect health. I mentioned one earlier, that Hawaiians are living longer. Okay. We're just not as long as other groups, so that's the concerning news. Okay. There has been some improvements like in infant mortality rates. We still have the highest infant mortality rates compared to other ethnic groups, but it's improved over time nevertheless. So there are some good news. Another good news that I want to highlight is the number of Native Hawaiians seeking higher education. Mainly in our community colleges here in the University of Hawai'i system, we see a substantial increase in the number of Native Hawaiians seeking college degrees now through our community colleges.
And you mentioned that education and affluence, or I guess a lack of poverty, has a huge impact on what you're seeing.
But education certainly is one of those social determinants of health, right? Higher education is associated with better health across ethnic groups. And so, of course, as we want our Native Hawaiian and Pacific Islanders to aspire to higher education, although the opportunities are challenging, right? Right. Nevertheless, higher education does afford them a healthier life, whether that's, it could be many reasons, right? Education, higher income, right. More resources, better health care perhaps, higher education perhaps, appreciation for certain types of diet, physical activity, and other factors. But it may actually be also related to less stress. And I talked a bit about how stress can lead to disease in our society. So education is one of those markers for many things that leads to disease.
Does that mean that as this particular generation advances and we see a much higher rate of Native Hawaiian people having college degrees, master's degree, PhDs, that we'll start seeing those indicators improve?
You start seeing those indicators improve on average, yes. But it's much like the improvement in longevity. We see an improvement in longevity, but there's still a gap when you compare it to other groups. So something's still happening. Right. There's something competing As we make improvements in one area that improves our health, there's other areas that still challenges that, and one still would be that social status. You know, if Native Hawaiians, which was really interesting, Native Hawaiians make up 25% of the state's population, when no one ethnic group is the majority.
Right.
And we intermarry with everyone.
Right.
So we have influence across the state,
Right.
but we don't enjoy a social and health status befitting of a host culture that size.
And
you think about it.
Yeah. Tell me why you think that is.
Well, I think of past discrimination, past overt discrimination. Perhaps there's remnants of that in our society still. That still puts Native Hawaiians and other groups at a disadvantage. Filipinos, Pacific Islanders, and so forth.
You mentioned when you gave me the presentation over at the Senate, there were some fascinating figures in there that showed spikes of disease and in different communities, and I kept noticing about 4 communities. I was wondering about that. Hawaiian, Ka'u, I think you may be Hana, and one other.
Native Hawaiian communities. I don't remember the exact 4. It's right in here. But yeah, those 3 were the top. 3 of the 4 were right there. Yeah.
And is that does that speak to that there's both a large concentration of Hawaiians in those communities, plus there are access to many different healthcare services that are lacking?
Lacking, right. Well, there's as many factors. One, they're among the most impoverished communities.
Right.
Resources are poor out there. As I mentioned before, they're what we call obesogenic environments.
Right.
Environments that lends itself to obesity, for example.
And the obesity rates, it's not just genetic. I know people sees it's Samoan, big bone people. We're talking about actual challenges to their physiology because of all these social determinants.
These changes in our diet and lifestyle, westernization. I always tell people being American is bad for your health, even for white people. And the reason why I say that is white Americans die younger, are fatter than their European counterparts. It has more to do, getting away from the genetic talk.
Yes.
Because as human beings, we share a lot of similarities genetically. There's probably more similarities between you and I of different ethnic groups genetically than there is dissimilarities. So we really got to move away from the genetic talk because it's giving our people the wrong impression. It's giving all people the wrong impression. Okay. Especially when we're talking about diseases of lifestyle, chronic diseases like diabetes, heart disease. But when you look at other countries, peer countries, countries who are developed like Germany and other European countries, Canada,
right.
You know, the U.S. spends the most money in healthcare. You know that.
Right.
But yet we have the poorest health of all those countries. So we spend a lot of money in healthcare. We do a lot of talk around healthcare. Right. But yet we're not doing well. In fact, we're getting worse. Obesity rates are getting up there, diabetes across all groups. There's something about the American culture, maybe it's the Protestant work ethics, work till you die, that is killing us. And I think it's really a lot to do with the types of stressors we see in our society.
I thought you were going to use the word because I think it does. That seems.
I think it's Protestants, by the way. I was baptized a Protestant.
Hey, look, I'm a Jew married to a Mormon, so I know I've got stresses galore at home by virtue of that, and I'm trying to keep my health good, you know. But I'll tell you, as we see the stressors build up in society, and it is interesting because the American society does seem to be built on stress. We don't have the European model where there's. It seems to be that you need some significant downtime to kind of recollect your life.
Yeah, exactly.
And you have less
connect with people.
Connect with people, with your children. There's less time with children. And it seems to me that what you're saying in the report is individual communities that have to additionally have not just the American conundrum of stress, but also a second job, struggling financially, difficult access to good education and health literacy, all those things.
Discrimination.
And discrimination. Then all of a sudden, so many stressors have built up that we're almost just, there's just too much water in our canoe to make it across the boundary to good health.
We have to work hard just to bail out all that water out of the canoe.
Right.
And we're not getting very far. But yeah, it's really concerning, and you know, I always like to use the Titanic as a really good example because it really covers the issue of genetics, biology, and access, and the issue of social determinants. And everyone knows the Titanic, right? It went down. But if you look at the Titanic, there was, you know, if you consider the ship as a country or a state, there's rules and regulations on board. And there's someone in charge, the captain. And on that ship, the rules say that women and children first in case of an emergency. And it also says, based on social status, who's first. And there was, on that particular ship, third class, second class, first class. And depending on your social status, which is arbitrary, it's based on what we value, money. So it determined where you were located, where you lived on that ship. So third class, you were on the bottom. Second class, you're in the middle. First class, you were on the top. You had the view. But it also determined access to survival.
Lifeboats.
Lifeboats, which was on the top, closer to the first class. And there was not enough lifeboats. So there was access to lifeboats, but the rules of that society said not everyone has fair and equal access.
Right.
And as you know, if you women and children, if you just look at women and children, third, second, and first class, you can break down their mortality based on what class they were. Basically, all first class women and children survived, and there's a substantial decrease as you went down to second class, and barely third class women and children survived. Very, very little. And I always tell people they were all white.
Yeah.
They were all white. Genetics had nothing to do with it. Behaviors in that case had nothing to do with it. Personal choice had nothing to do with it. It had to all do with the rules and regulations of society and what we valued. And people with a lower social status were less valued and therefore less likely to survive when that emergency came.
And your metaphor is basically the description of the social determinants of health.
The social determinants of health, exactly. We create these social constructs. But believe it or not, it plays out. I mean, we buy into it.
Right.
And because of that stressor, and some this great work looking at it's just not inequalities or inequities. It's knowing that they exist and it's unfair that is really the stressor. When you look at in society, imagine if 95% of us were poor and only 5% were rich. Probably wouldn't be too much of a problem, because my neighbor's poor, everyone I know is poor.
Right.
Life is just poor.
Right.
But we live in a society where you can go across the street and someone makes substantially more than you. I mean, you go to some communities, one community, and you've been there in probably North Kohala side and so forth.
Sure.
Old generation, families been living there for a long time,
Yes.
From plantation days, and then you have trust fund babies come in, and all of a sudden they're living right next door, and they're wealthy, and they don't need to work.
Right.
You can imagine the social comparison that happens. And we see that when you look across countries with a larger income inequity,
Yes.
and the U.S. has one of the largest income inequity, is directly associated with health and social status. So the larger the income inequity, the poorer the health and social status of that country on average.
Interesting.
And there's something to do with those kind of inequities that is playing out and adding, I guess, an added burden on people.
Do you think that we're seeing that in Hawaii in addition to the mainland? Because I have noticed and I've read a little bit about there's a very significant wealthy core of people here, both people that have dreamed of moving to Hawaii for a lifetime, and they come in rich from other countries included, from Japan and now China. And then those of us who are living here working in the middle class, without resources at all. Is this adding to our problem?
I believe so. We've done a number of focus groups in different communities across the state. And one of the things we do here, especially on the Big Island, I've done a number of focus groups on that island looking at health and well-being. And one of the big things people say is what's happening to our communities as, what they might call outsiders coming in. It changes things, a different culture, a different way. I mean, a lot of them will say that they start to buy up properties near the beach and they close off access to the beach. And their kids have to walk along the freeways to get down the road, which puts them in danger.
Right.
And there's a lot of challenges, differences in perspectives and cultural differences, that now there's clashes within our communities. And so it becomes frustrating for a lot of our people that work very hard in the state, and it does seem apparent or seem like we're not getting anywhere. I mean, I'm a professional.
Right.
I make a fairly decent living.
Right.
But even just to buy a home, if you don't have accumulated wealth, I don't have parents who even owned a home.
Right.
So I can't borrow off of their equity.
Right.
So I have to start from scratch, and a lot of our people are faced with that. And come on, I'm a graduate of our public school system here in Hawaii. I had to relearn everything when I went to college.
Right.
I really had to start all over again. And we really need to direct more resources to our public school. And we need to pay our teachers more.
I'm glad you're talking about those things, because I know our show is healthcare in Hawaii, but it's really about so much more. A person's health, no matter what ethnicity they are, is going to be tied, as you've spoken very eloquently about today, it's going to be tied to their socioeconomic class. It will be tied to their ethnicity. But to speak about racism, to speak about people's sense of stress because of the many challenges that are different than whether or not you have a good cardiologist in your neighborhood. I think people are going to need to learn that the healthcare challenges we have in the country are more about those things and less maybe about the simple things that we might see emerging from the dialogue in Washington about the Affordable Care Act or taxing this or that.
Exactly.
So I think that that's where we'll bring ourselves to in our next segment, as we have already established very clearly that we have challenges that are much greater than the healthcare system for the Native people of the state of Hawaii. So with that, we'll take a break. This is Josh Green, your host at Healthcare in Hawaii.
We want to thank our underwriters.
Hawaiian Electric Company and its affiliates Maui Electric on Maui and Hawaii Electric Light Company on Hawaii Island are deeply committed to the communities they serve.
Galen Ho is a senior executive of BAE Systems, a global defense, security, and aerospace company.
The High-Tech Development Corporation, the state's leading technology agency, attached to the Department of Business, Economic Development, and Tourism.
Castle in Kauai, with a time-honored legacy that spans more than 160 years and revolves around its mission of investing in Hawaii, creating communities, and providing for the needs of our state.
Hawaii Gas, formerly the Gas Company, a proponent of the Liquefied Natural Gas Initiative, helping Hawaii achieve its transition to clean energy and a better energy future.
Collateral Analytics, a Hawaii-based tech company empowering the real estate industry with greater and faster access to the tools and data they need to make better informed property investment decisions.
I'm Nicole Horry. Thanks so much for joining us on ThinkTech.
I'm Maria Kashem. See you next time.
Aloha, I'm Josh Green, Chair of the Health Committee at the Senate on Healthcare in Hawaii, your host today. Today I'm lucky enough to have Professor Keawe'aimoku Kaholokula, who's a PhD at the University, Chair of the Department of Native Hawaiian Health. He's been eloquently describing the social determinants of health for us here in our state. He's really the expert on healthcare challenges that the Native Hawaiian people have. We've spoken about the many different stress challenges that force people into a position of I guess, unfair health conditions, if I was going to be blunt about it. People that end up having health problems like diabetes, heart disease, hypertension, much earlier in life than they should. And it's not simply about genetics, we've discussed. We've actually unpacked this problem, and it's really about things like racism. It's about economic challenges. It's about many challenges that occur in Hawaii with people migrating here, but maybe not understanding the host culture properly. It's about respect, actually. But I want to begin to turn the conversation to the positives, because you're doing so much good work on the solutions, Professor.
Yeah, there's a lot of good news happening in our communities. We work with a number of Hawaiian and Pacific Islander communities across the state. And one of the big projects we've had for the last 9 years is the Pili Ohana project. And the Pili Ohana project has been looking at developing community capacity to address for communities to address their own health. I have a particular goal. My goal is really to take healthcare out of the clinics and hospitals and put it back where it was traditionally in all societies, in our homes, in our communities, with our leaders, with the people within our families, the people we trust. And so I really believe that if we're going to address health disparities and eliminate health disparities across all groups, we really need to go upstream. We really need to go where people live, work, and play.
Tell me about the Pili Ohana program. What does it mean? What does it do?
So the Pili Ohana, Ohana, as you know, is family in Hawaiian. Right. Pili is actually an acronym here, but Pili also means to come together, to join, to be linked. Pili is an acronym also for Partners in Improving Lifestyle Interventions. Okay. And so we've come together with, we actually started with 5 distinct Native Hawaiian and Pacific Islander communities 9 years ago.
Where were they? Which ones?
Yeah, they were Papakolea Homestay Community along with Kalawahine and Kewalo that they serve up there.
Yes.
The Keawe'aimoku Native Hawaiian Healthcare System here in Oahu. Yes. Kokua Kalihi Valley Family Comprehensive Services in Kalihi.
Great work.
And Kalihi Palama, as well as the Association for Hawaiian Civic Clubs through actually one of their nonprofit arms called Hawai'i. And with them as partners, I mean, very close partners, they pretty much co-led the entire study in which we actually went around to different Hawaiian and Pacific Islander communities asking them what they thought about the issue of obesity in their communities and what might be the best solutions. What were the challenges in their communities? And we took that information and we worked on developing a lifestyle intervention, or what we call the Pili Lifestyle Program. And initially was to address the issue of excess weight, overweight and obesity. Why is that an issue? People who are overweight or obese are more likely to develop diabetes and heart disease.
Sure.
So if we can actually tackle that problem, we're actually tackling diabetes as well, and cardiovascular disease. And so we went ahead and developed an intervention, a 9-month-long intervention. At the same time, we also developed a diabetes self-management program. The good news is it was entirely community-placed and community-led.
Right.
The facilitators for the groups, the intervention of the programs were from the communities. They're peer educators. And what we learned over these years, one is that we can address, our communities can do a great job at addressing their own health.
Right.
So our studies, our programs have shown significant reductions in weight in people who could benefit from that, significant improvements in blood pressure, as well as physical functioning. And our diabetes program showed significant improvements in hemoglobin A1Cs, their average blood sugar levels over time. And as you know, the goal is to get them under 7. And we've shown substantial improvements in these programs delivered entirely by community folks. And the good news too is we had a range of people delivering the interventions. We had nurses, public health professionals, social workers, and we had lay people, many who have never gone to college. But I tell you what, those lay people are just as, if not more effective in meeting the outcomes I mentioned earlier than us professionals, us overpaid professionals. And it's really developed a momentum, if you will. And from that 5 organizations over 9 years ago, we've expanded across 17 distinct organizations across the state. And over the next 3 years, we have more federal funding to disseminate widely.
Interesting.
And so our goal is really to, because we believe we have an evidence-based intervention. And it's evidence-based because it's been scientifically tested through a randomized control trial. And it's probably the first 2 for obesity and diabetes that was ever established with Native Hawaiian and Pacific Islanders.
I'm guessing this is going to also have an intergenerational benefit.
Exactly. Well, it's focusing on family and community. So what's unusual or unique in a positive way about our intervention is we realize that these changes we're asking people to make, it's not about the individual, it's really about the family. The individual wants to make change, but everything's competing. And the more they can get the family and community resources and supports in place that they need, the more likely that individual can sustain these changes. And so we really work on that with people, identifying the supports in their family, how to design their home so it's healthier for them, get their family on board, include their family in their healthy lifestyle plan, as well as despite the fact that many of our communities, like I said, are obesogenic, there are great things that we can find that can help people. They can still do this, things that can happen. Even going to a fast food restaurant, you can still make healthier choices. And we cover those things. And we're seeing now, as a result, the added benefit beyond just the intervention itself is that communities are mobilizing and looking into other areas. They're saying, if we can do it in this area, why can't we do it with this other issue in health, and so forth and so forth. So we're seeing a ripple effect. We're seeing capacity being built. We're seeing participation in our communities increasing as a result, which is great news. It's great news. And I suspect that as this continues to happen, our communities become leaders now with us in this healthcare movement. I mean, wouldn't you rather hear as a senator the voices of our community folks where our healthcare really impacts?
I absolutely would. And I think that it's so good what you're doing, because by doing it from the true ground, it's a lot easier to get to a place where people have profound health literacy in a way that makes sense in their community, rather than to try to find a way, a miracle Hail Mary pass to build a fancy hospital where people might not even go. It sounds to me like one of the strengths of the program is that by incorporating the very people of the community, you don't see that reluctance to go and seek care from an outside or from the other. Probably some of the questions of racism dissolve, because again, it's the people in the Ohana, And then on top of it, I would say it's probably the return on investment must be incredible, because you're directly putting those resources into the actual community.
And the payback is tremendous, what you get out of your investment. You get so much more.
And will we be tracking over time the rates of diabetes, the rates of hypertension, and so on in out years? How will that work?
That is actually something I'm interested in doing. Seeking additional funds to go back to our former participants and actually collect that data, because we can do that. in retrospect. So it's one of the things we're looking at. So no, we haven't been doing that during our study, but what we do know is that modest decrease in weight and someone with excess weight affords them a huge health benefit. For example, just losing 2 pounds for someone who has excess weight, you already reduced, and studies have shown this, your risk for diabetes if you don't have diabetes yet by 16%. Modest weight loss, modest weight loss. 3% body fat loss, 3% of your initial body weight loss. Right. Already we see blood pressure improvements and so forth. As you know, hypertension, high blood pressure is a risk factor for heart disease. So modest changes, we see huge improvements long-term clinically.
Right, and then on top of that, I think that you have a very positive psychological impact on people that actually see positive change, positive results. In my experience, at least in healthcare, the successes breed further successes in people. People have spent so many years struggling and in many cases failing to improve their health. And when they finally see a success, they will build on that. They will then be more interested in an exercise program, more interested in a community garden, more interested in, if they learn from you that their whole generation of families their health will be improving if they go and get higher education. Exactly. They'll make that commitment.
It empowers people, and when you empower people, you know, the sky's the limit. And the great thing about what we're doing is we're really moving away. You know, most often our interventions are very stringent. They're tough. You're asking people to exercise, aerobic exercise, 40 minutes a day is not a recommendation, right? 40 minutes a day, eat so much, you know, watch your caloric intake. We're asking people to do complex math for a lifetime. People can't do that. So a lot of our interventions are really geared towards the real world situation. What can people, what can they manage and what can they sustain over time? You know, we're great at getting people to make behavior changes in 3 and 6 months. But when life hits, something changes, that all falls to the wayside. Because it's not sustainable, it's not realistic. Sometimes it's just overboard. But what we're trying to do is make these changes manageable, and we allow people to identify the changes they want to make. It's not a prescribed thing where you have to do this. We work where the people are at, and we work towards a goal, and they set the goal. And you'd be amazed that people do set wonderful goals for themselves, and they can work towards achieving it. And I think that's the attractive part of our interventions, is that people within the intervention have a lot of autonomy. Because most often, and when you go to some of our clinic-based, hospital-based, it's prescribed. Right. You take this 2 times a day, you do this 30 minutes a day, and come back and see me. And it doesn't allow that person to interact and come up with that strategy themselves and what's manageable for them. But you know, we've taken a different approach, and we think our approach seems like it's working.
Excellent. I think this is a good time to take our third break for the afternoon. Again, this is Josh Green, Healthcare in Hawaii. We're going to come back in the final segment and talk about a vision for healthcare from our professor. Thank you again for joining us today.
Aloha, I'm Jay Fidel of ThinkTech Hawaii. We have a program with the Hawaii Venture Capital Association on October 24th, Thursday, entitled Newsmorphosis 3 Online. Is our online news media doing its job? We have Jerry Burris for opening remarks, Howard Dykes is moderator, and a blue ribbon panel of journalists to discuss exactly what's happening in online news. Sign up at hvca.org and come on down and see us, network, enjoy the discussion, raise your awareness on ThinkTech at this program. October 24th, we'll see you there. Aloha, I'm Jay Fidel.
Aloha, welcome back. I'm Josh Green, your host for Healthcare in Hawaii. I'm joined today by Dr. Keawe'aimoku Kaholokula, who's a faculty member. He runs the department at the Department of Native Hawaiian Health. He's the chair of the department, and he has vision on how to make people healthier in his community and across our whole state. I want to talk in our last brief 5-minute segment about a vision for the future of healthcare, because you really are in touch with actual community. You've seen where the challenges have been for a generation, and I think you can see what we need to do for tomorrow. Yeah. So this is your chance.
Yeah, well, a lot of vision, but one of the things I envision is really, as this new healthcare system emerges from Obamacare, or the Affordable Care Act, is how do we, as I mentioned earlier, how do we build communities to address their own health through preventive services? Yes. And how do we link that with our healthcare system, the local community health center, the hospitals, so that larger healthcare system is not your traditional units of care, the community health center, the hospitals, and so forth, private physician offices, but it really includes our community folks that can do a great job and work with our physicians, healthcare providers in addressing their health. It doesn't have to be something where you have to leave your community and go to a clinic to do. That's my vision. My vision is building a holistic, comprehensive healthcare system that truly involves our community people as partners. And what I envision is where their role is really with preventive care, lifestyle, stressing, obesity, diabetes, self-care. I mean, when you leave the clinic, you have a community to actually now follow up with the doctor's recommendations.
But that would come after. The community health center or the hospital would really be very secondary in that.
Secondary, and ideally in preventive care. But it really is a partnership. That's one of the things I envision. Our Native Hawaiian healthcare system, as we know, through federal legislation, we have the Native Hawaiian Healthcare Act. And as a result, we have the Papa'ololokahi, the Native Hawaiian Health Board, and our Native Hawaiian healthcare systems, 5 of them on the 5 major islands. And how does that system now interfaces effectively with the existing healthcare system and with our communities, our Hawaiian homestay communities? And as I mentioned before, one of our Hawaiian homestay communities can serve as a model, Papakolea, of what amazing things they're doing in their community to address their own health. And I think this can be replicated across. That's one of the visions I have. Another vision is we need a different kind of healthcare provider for the future. We need to develop our young people.
Yes.
In our Native Hawaiian community, what we have now is the opportunity to develop leaders that are culturally grounded and solid in their Hawaiian heritage, as well as understanding the Western world and being able to integrate the best of these two worlds to deliver the best healthcare and the best science, not just physicians, but also scientists. It's not until we have people from these ethnic groups, cultural groups, disadvantaged groups coming into these professions that can address their concerns, we're not going to be asking the right questions.
Mm-hmm.
Yeah?
Are you seeing, for instance, in your work with Pili'ohana across the state, which really seems to be an extraordinary program, are you seeing these young leaders emerge? Is that where you're going to be finding them?
I see these leaders emerging right from the community themselves. As a result, yes, several of them. One community person, I probably shouldn't say her name, but very proud of her, from Papakolea.
Give us her name.
Adrian Dillard.
Yes.
This person, over the course of 9 years, we've seen her go to college, get her BSW, her MSW. Now she's a doctoral student at the University of Hawai'i in social welfare.
So she'll be returning with her doctorate back to the community.
She's already in her community. And she's going to apply that science, that knowledge, to the benefit of the community. And we also have other people in other communities that go on for their masters in public health, getting their PhD in nursing. So these are wonderful things that are happening. And they're from the community. They're not outsiders coming in.
Right.
And they're going to be able to better address the concerns and develop trust, which is a big issue for many of our people. Another vision is JABSOM plays a major role in developing our healthcare workforce.
Right.
And it's very important. I talked a lot about community health, a lot about social determinants of health, but it's very important that we get more healthcare providers, physicians, nurses, psychologists from these different ethnic groups coming back in and building diversity. And as we get these people coming in, what we see is they're more likely to go back out to their communities and serve. So as we get Native Hawaiians, Pacific Islanders from the neighbor islands coming in, they are more likely to go back and serve.
I remember I was touched by a comment you made maybe 5 or 6 years ago in a hearing, and I was listening carefully to you because I could immediately tell that you were in tune with the challenges across the community. And you told me and the committee members only 7% of our healthcare workforce was Native Hawaiian, but 25% of our population was Native Hawaiian. Yeah. And it struck me as, of course, a very basic challenge, right? Then, well, surely common sense would suggest we have to increase that number very significantly, but the impact is going to be even greater, I think.
On everyone. The 25%, we need to get 20. If 25% of the state's population are Native Hawaiian, we need 25% being in business, 25% in education, 25% being in politics, 25% across the board being physicians, psychologists, nurses, social workers. It has to happen, and it will happen. It will happen eventually as we work towards that. And at JABSOM, we're trying our best to get more Native Hawaiians in.
What are the programs? You've mentioned them to me before. What are some
we have Imihola, our post-baccalaureate program, and it's designed to get students like Native Hawaiian students, Pacific Islanders, give them an opportunity to go to medical school, especially those from socially disadvantaged backgrounds who don't come from families where there's a physician in the family and so forth. We also have our Native Hawaiian Center of Excellence, which is designed to build diversity in the medical field and address, as you know, our workforce shortage here in the state, especially on neighbor islands. And so we're working very hard at doing that. And mahalo to you for being a strong supporter in that movement and initiative. I know we owe a lot to you and your colleagues for that vision. But you know, another vision I have, and it's a larger vision for the state of Hawaii, and it focuses on Native Hawaiians. But as we address that issue, I think it'll have a ripple effect on everyone in the state. You know, I talked about the social determinants of health, and if we are to really truly address the health of a people, we have to address those social determinants. And I envision, you know, that as we move towards improving the circumstances of Native Hawaiians, we improve the circumstances for all. But we need to create the social cultural space in place for Native Hawaiian culture and people to feel valued and able to exercise their aspirations and preferred modes of living. It's really interesting. We work, you know, in the state, we use Hawaiian culture for everything from education, promotion, tourism, slogans for promotional ads for businesses, you know, workplaces. We use, you know, all these Hawaiian values to encourage solidarity and so forth. Right. But yet the people seem to be neglected, the Hawaiian people behind the culture. Hawaiian culture is promoted, but the people seem to be left behind. And without the people of that culture group, we really have no culture.
And you're saying strengthen the people.
We need to strengthen society. We need to create a space and place. I call it Keawe'aimoku, a native space and place. We need to, Hawaiian language needs to be visible for our people. It needs to be functioning in everyday society. We need to remove ourselves out of it, just simply entertainment and education, and our culture needs to be across the mainstream. Malama Aina is another area we need to focus on, healthier communities for our people. Hawaiians and Pacific Islanders live in the unhealthiest communities. We got to fix that. And those are political decisions of where sidewalks go, where median strips go to prevent head-on collisions, where good parks are maintained. Those are decisions made upstream. We need to, you know, create Malama Aina. The other thing is Ka'aipono, the behaviors, healthier choices. But people cannot exercise healthy options if they don't have the environment to do so and feel secure in that environment and appreciated to do so. And then ultimately, Kawaiola is social justice. We need the burdens and benefits of society to be spread across all equally, equitably, and not just one ethnic group or a few. And that's the vision I have. Now, a lot of these things are larger issues around education, resource allocations to better education for our public school systems where most Native Hawaiians, Pacific Islanders, and Filipinos go. Healthier communities, access to natural resources, and decisions made with Hawaiian perspectives and Hawaiian leaders at the table. You'll find that there's great solutions in our Hawaiian communities and great traditional knowledge that we're turning to now in land management, resource, ahupua'a concepts. Yes. A lot of the things that are ancient knowledge to our people are being revisited by a lot of our leaders in these areas because it seems to make sense now that we've learned through trial and error that other things may be depleting our resources. So there's a lot of opportunities here, and that's what I envision.
And I think it's really commendable for you to speak about social justice when we're talking about healthcare, because I don't think it occurs to so many in the rank and file that are involved in healthcare. And to begin to talk about social justice for our people and for our society is, I think, what Obama envisioned.
Exactly.
And I think that that's what you envisioned.
Exactly.
So I think that's an extraordinary place to wrap today. I wish we had more time, but Professor, thank you for joining us here in Healthcare in Hawaii.
Appreciate it.
We have great things to see ahead, I think.
Thank you.
So again, thank you everyone for joining us here today in Healthcare in Hawaii. We'll be back again next week, and we're going to continue to explore all of the challenges that Hawaii faces in the healthcare system. But today we focused on something new, social justice and how it impacts healthcare. We're going to make this an exciting discussion going forward. Thanks for being here.